Hi there, my name's Nav Kapur. I'm a psychiatrist and an academic based at the University of Manchester, and I'm also really pleased to be one of the honorary consultants in psychiatry at Mersey Care. I'm going to be talking to you today about self-harm. It's a big problem, a problem that's been around for a long time, and thinking with you why really we need a new approach to self-harm, why we might need to think about new care pathways. So the first thing to say about self-harm is it's common. So it's one of the commonest reasons for medical admissions in the UK. Every year in England there are at least kind of 200,000 episodes, 150,000 people. So it's a common problem, and a big part of the workload of many liaison psychiatry teams across the country. What about trends over time? For a long time, people had said to me, "Oh, well, self-harm is becoming much more common, isn't it now? It's a real kind of crisis." And I don't like those terms. I don't like kind of people sensationalizing self-harm. But we always used to say, well, we think it's probably people being more aware of self-harm rather than actually self-harm actually going up. In fact, one of the things about doing research is you get to prove yourself wrong, and we've proved ourselves wrong on this one, unfortunately, really. So this is looking at self-harm episodes in girls. So this is young people. This is in primary care, so it's not emergency departments. It's a slightly wider lens we're looking at things through, really. And what you can see here is actually a steady increase in self-harm in girls, and actually post-COVID pandemic that's increased more dramatically, and you'll see these increases in other groups as well, and I think it is a problem we're worried about, and it is a problem that does appear to be growing. So it's common, it's possibly increasing. What about its link with suicide? I think this is another reason that we've got to take self-harm very seriously. So in the year after someone presents to your emergency department with self-harm, having taken an overdose or hurt themselves in other ways, their risk of suicide is increased between kind of 30 and 50 times in the year after they've attended. And you can kind of express that in even more an even more kind of stark and striking way. So this is data from a study we did a little while ago, but it's tens of thousands of patients who've self-harmed in Manchester, Derby, and Oxford. And the top line there is showing you the life expectancy in men who have self-harmed. It's the life expectancy of men in the general population, so that's around 80 years. This line here, the second line here, is the life expectancy in men who have self-harmed. So this is looking at deaths from external causes, so it's not just suicide, it's accidents, misadventure deaths, etc. But the message is pretty clear. Men who have self-harmed have, if you like, half the life expectancy. In other words, self-harm is associated with about 40 years of life lost. It's a similar story for women, slightly fewer years of life lost, between 20 and 30. But the next time someone says to you, "Oh, self-harm isn't serious, is it? It's just kind of attention seeking," I think you can absolutely correct them. This is a serious behaviour. Every episode needs to be taken seriously, and it is strongly linked with suicide. So it's a common problem, possibly getting more common, associated with suicide. How do we do in terms of care for self-harm? So here's a study we did a few years ago, back in 2010, where a colleague of mine went to 32 hospitals in England and just looked to see how people with self-harm were kind of managed, really. And this is the proportion of people who got a psychosocial assessment. So everyone's supposed to get assessed after self-harm, but what we found in this study was it was really variable, and that's what I want you really to look at, the variability. So in some places only about a fifth of people got a proper assessment. In other places it was close to 90%. So there's huge variability in the care of self-harm. It's not the only thing. It's not just the variability. There's a fragmentation of care. So this Samaritan's report that you should look at. It's called Pushed from Pillar to Post, and that describes it very well. It describes how people with self-harm getting referred in and out of primary care, being referred to secondary care, but then not being accepted, talking treatments, not getting them. So care that's variable, but care that's also fragmented. Sometimes, I come across examples of excellent care, but actually still, unfortunately, as well as care being variable and fragmented, sometimes the care isn't as good as we would like. So this is from a systematic review that colleagues undertook in Oxford. So this is, from a service user, from a patient, their account of what happened when they went to the emergency room. Wouldn't touch me. They looked at me as if I'm saying not touching you in case you flip on me, and it was actually kind of their attitude that came across. So sometimes we don't do as well as with self-harm as we would like as clinicians. So we've got things to help us. So clinical guidelines, nice guidelines for self-harm. I'm hoping most of you will be familiar with these. These are ones we published in 2022. I was the expert advisor on these, and they're there to kind of help us. They're there to kind of highlight some of the key things we might want from a care pathway, key things we might want from clinical care. And that starts, of course, with first contact. When someone appears at the emergency department, what's our first contact like? And what you're going to get now is a few slides with some things taken, extracts taken from the NICE guideline. In some respects, it's surprising we still had to say this in 2022 that health professionals, one of the first priorities is to treat people who self-harm with respect, dignity and compassion. I think that's an indication of where we're at. We've, I think, made some progress, but we've got quite some way to go, but that's really important. And the other priority is, of course, to keep someone physically safe. As soon as we can, the guidance is to refer to an age-appropriate liaison psychiatry service, where hopefully people will get an assessment. And the guidance again is clear, although I've talked to many of you, have walked through some of the services in Merseycare. Basically the ask is every episode of self-harm gets a psychosocial assessment, and I know sometimes that's very challenging, with the volume of people coming through emergency departments in the region. But that's the guidance. It's a psychosocial assessment, and we know that's effective. So some of the studies we've done over the years, we know that just doing a psychosocial assessment might reduce the risk of self-harm on its own by 40%. So just you doing the assessment can be therapeutic in itself. And a lot of people ask about the content, but actually with a lot of things in self-harm, the how is just as important as the what. So it's not just about the exact questions that you ask, it's about how you ask them. A collaborative assessment, developing a shared understanding. What are some of the other principles as well? I mean, do the assessments quickly, taking into account needs and preferences. And again, something that's been really challenging in a lot of emergency rooms in the region, having a private designated area where you're talking to someone in private and not, unfortunately, as sometimes happens, behind a curtain where people can hear. So a private designated area is really important. How can something as simple as just an assessment work? How does that reduce repetition by 40%? Well, there's something there about the assessment itself. So when you ask patients, what worked about the assessment for you? So something about the person actually caring, that therapeutic engagement, but also there's something about the access to aftercare. So if we do a good assessment as clinicians, then basically we can plug people in to the aftercare that they need. Here's again some data from a qualitative study we did, a study where we were actually asking patients what they experienced. So you've got the first contact, you've got a kind of comprehensive assessment, that you've done. The other thing, of course, that you might do is a safety plan. We're all very familiar with these by now. There's research out there on safety plans. Here's a couple of reviews. The research isn't quite as strong as you might think. So one of the things people like me look for when we're looking at guidelines is randomized controlled trials where half of people get one intervention, half of people get another intervention. There aren't that many randomized trials for safety planning. On the other hand, I think there's fairly good evidence that they're a good idea. So I think they are a good idea. We should definitely be doing them. And this first systematic review in the British Journal of Psychiatry, this second one's quite interesting because it talks about some of the things that might be particularly effective about safety plans. So having safety plans that are accessible, personalised, that involve others and are collaborative. And that was really picked up in the NICE guidelines when we look at what the NICE guidelines say about safety plans. It's one of these where the content's important. So, the what's important, but the how is just as if not more important. So develop them collaboratively and compassionately, share them, make sure they're kind of accessible. Those principles are at least as important as what's in them. And actually there's no role really for safety plans that we just kind of, tick box exercises that we just complete in a formulaic way. It becomes kind of risk assessment, if you like, by another route, and that formulaic tick box exercise to risk, many of you will have heard us talk about isn't a fantastically good idea. So safety plans, the how is just as important as the what. So you've made first contact, you've done your assessment, maybe you've done a safety plan. What about aftercare? Aftercare is really important. Two things I think about aftercare. The first is, just making sure that the person is signed up to the kind of aftercare that you're offering them, know the rationale for why you're offering it. But then also the speed of aftercare. So, sorry, you can't see all of this recommendation, but offer initial aftercare within 48 hours of first presentation. Why is that? Well, again, we're going back to the research here. This is looking at the timing of repetition in people who've self-harmed, and 1/3 of people who are going to repeat self-harm within a year do so within the first month. Okay, and you can break this down even further. 10% of people who are going to repeat do so in the first 5 days after presentation. So, that early period is really important. Why we pick 48 hours here? It's really, if you like, extrapolating, drawing on the evidence for post-discharge care, the 48, 72-hour follow-up. So we're making this follow-up after self-harm kind of consistent there. So make sure the patient knows what you're offering them in terms of aftercare, but get in there quickly, because actually otherwise in some senses we might be wasting our time. A lot of the repetitions happen early. A lot of the high risk period is early, so that similar principles apply around suicide when you break it down. So if you're gonna intervene, let's get in there early. So we've got initial aftercare, but then what about the longer term? And this is where I think some of the care pathway stuff comes into its own, really. I mean, self-harm's a behaviour. It's not a diagnosis. It's a behaviour, and as all of you know, I don't need to tell you, a lot of people harm for lots of different reasons, and there's lots of often underlying conditions that might be contributing. So it's not always a mental health disorder, but sometimes it is. And if it is, if it's a mental health disorder, if it's a physical disorder, if it's a kind of social thing, those are things that need treating. So, one of the important messages from NICE is you treat the underlying conditions, and there's lots of different guidelines for any, most of the underlying conditions you might think of. So treat the underlying condition. But the other thing, and I think we've not been as good at this in the past as we should have done, is offering talking treatments. So psychological treatments, talking treatments after self-harm are effective. So the guideline talks about CBT informed psychological interventions. In fact, when you look at the interventions themselves, a wide variety of different things, interpersonal therapy, psychodynamic therapy, brief psychodynamic therapy, problem-solving therapy, CBT, cognitive therapy. So a wide variety of different therapies designed for self-harm. But the bottom line is here, this is a forest plot. These are individual randomized trials, and what you do in a systematic review is you can combine them. And I don't want you to worry about any of the detail here. All you need to look at is the black diamond. The black diamond here, which is to one side of this line. So this line is the line of no effect. So it would mean that the psychological treatments make no difference if the black diamond was on this line. In fact, to this side of the line, which means that giving a psychological treatment, a talking treatment after self-harm reduces the risk of repetition by between 40 and 50%. So it's a really important principle. And up until recently, most areas in the country didn't offer timely access to psychological therapies, to talking treatments routinely after self-harm. It just wasn't happening. So, as part of the care pathway, this is something that's there, and I think a really important component of any intervention, any care pathway you might want to offer, because I think this could make a big difference to people who self-harm. But it isn't just us, of course. It isn't just people who work in mental health care, and that was one of the really important messages we wanted to give in the NICE guidelines. It's kind of everyone's business. Everyone's got a role to play. Self-harm can appear, can manifest anywhere. The third sector, really important partners for us in all of this. It isn't just mental health services that are going to be able to provide the care that people need. This harmless Samaritans involved in service provision in many areas of the country. In other areas, including locally, we've got other providers involved. But third sector, voluntary sector, really important partners in all of this. The other really important partner, I think, is primary care, is general practice, and often neglected if we're thinking about suicide prevention or self-harm. People do go to their general practitioners after self-harm. After they leave our emergency rooms, we often refer people back to their general practitioners. Really important setting. So this was a study that really focused on self-harm exclusively in general practice, first authored by Matthew Carr. This is quite interesting in a way. One of the things we're often concerned about is socioeconomic drivers of mental illness, socioeconomic drivers of self-harm. So this is deprivation quintile. So this is the areas in which people live and how common self-harm is according to deprivation. So people who live in deprivation quintile 5, they live in the most deprived areas. And what you can see here is, perhaps not surprising, a steady gradient. So people from, if you like, more affluent areas are less likely to self-harm than people from more deprived areas. And we know that, mental illness, self-harm, suicide, has a strong socioeconomic gradient. What's really striking about this slide, though, is something called the inverse care law. So even though people from the most deprived areas have the highest rates, have the highest numbers of self-harm, according to quintile, they're least likely to be referred to mental health services. So if you're coming from the least deprived areas, most affluent areas, you're less likely to self-harm, but of those people who do self-harm, more are referred to mental health services. In the high deprivation areas, in people who live in areas with high deprivation, they're least likely to get referred. So they've probably got the highest needs, but they're least likely to get referred. So it's an inverse care law. So that's something we need to think about. Need to think about how people are treated. So 2/3 of people receiving kind of psychiatric medication in primary care with self-harm. Psychotropic medication isn't a first-line treatment for self-harm. First-line treatments are treating the underlying disorder and talking treatment. So that's something we need to think about and look at. And very few, only 15% are actually ending up getting referred to mental health services. So perhaps a bigger role there for us. Perhaps a bigger role there for voluntary sector colleagues. You know, I've described self-harm as, real opportunity for suicide prevention. I've described primary care as a really important, setting for all of this, for self-harm, for suicide prevention. So here are some of the things that might make self-harm care better in primary care, some facilitators and barriers. This is published by my colleague Faraz Mughal, who's an academic GP in Kiel. Here are some of the facilitators, so things like GP training, improved communication guidelines involving young people and their families. And we're familiar with some of the barriers, so service provision, referral thresholds, not being able to get assessed, not having the services in place. So facilitators and barriers. But perhaps the most important group that we can involve in self-harm care, it isn't just us, is family members and carers, and the default really should be to involve family members and carers. Obviously not for everyone. For some people, clinically it's not the best. Most people it is, and that should be the default position. And we shouldn't, as we have done in the past, hide behind this idea of confidentiality. So obviously patient confidentiality is really important, but with people's consent, we should be involving family members and carers, because that improves outcomes. There's lots of resources out there. So this is from the NICE guideline, but this is a resource from the Zero Suicide Alliance that really thinks about the practicalities of how you involve families in all of this, because I think that's a really important component of any care. So here's a summary. Self-harm, we know, is common. One of the commonest reasons for medical admission. It's associated with suicide. It's possibly increasing in incidence. But the care is variable, it's fragmented. It isn't always as good as we would like it to be. But there's quite a lot of evidence there to guide us about what high quality care looks like, and we've got an opportunity to do this. So it's the first contact. It starts with the first contact, but then the first assessment. We're talking about the how of the assessment. Respectful, kind, collaborative. We've not talked about it too much today, but these formulaic approaches to risk, stratifying people low, medium or high, giving people a risk score, that probably isn't terribly helpful. That's the holistic assessment that's going to be helpful. Aftercare, communicate well with a service user, make it timely. Treatment, that's underlying conditions, but also talking treatments and other things that we can provide as part of interventions. And it's everyone's business. So the third sector, primary care, lots of others. There's lots in the guidelines about teachers, education and others. But I think, the other thing is service user and carer involvement. And that's not just in individual assessments, but also in designing care pathways, in providing services. So thanks for listening. I hope that was helpful. The last thing I always like to do is thank all my brilliant colleagues here at the Centre for Mental Health and Safety at the University of Manchester, who do all the hard work. Thanks again.